overall amount of water. And they even make hormones. The bottom line is that the kidneys do a ton of stuff. Blood gets into the kidney through the renal artery. And once inside, it goes to tiny clumps of arterioles called glomeruli, where it's initially filtered. And the filtrate, which is the stuff that gets filtered out, moves into the renal tubule. And they even make hormones. The rate at which this filtration process takes place is known as the glomerular filtration rate, or GFR. In a normal, healthy person, this is somewhere around 100 to 120 milliliters of fluid filtered per minute per 1.73 meters squared of body surface area. This value is slightly less in women than men, and it decreases slowly in all of us as we grow older. One of the most common causes of chronic kidney disease is hypertension. In hypertension, the walls of arteries supplying the kidney start to thicken in order to withstand the pressure, and that results in a narrow lumen. A narrow lumen means less blood and oxygen gets delivered to the kidney, which leads to ischemic injury to the nephron's glomerulus. Immune cells like macrophages and fat-laden macrophages called foam cells slip into the damaged glomerulus and start secreting growth factors like transforming growth factor beta 1, or TGF-beta1. These growth factors cause the mesangial cells to regress back to their more immature stem cell state known as mesangioblasts, and then those mesangioblasts secrete extracellular structural matrix. This excessive extracellular matrix leads to glomérulosclerosis, which is hardening and scarring, which diminishes the nephron's ability to filter the blood. And over time, this leads to chronic kidney disease. The most common cause of chronic kidney disease is diabetes. In this situation, excess glucose in the blood starts sticking to proteins, a process called non-enzymatic glycation, because no enzymes are involved. And once inside, this process of glycation particularly affects the efferent arteriole and causes it to get stiff and more narrow, a process called hyaline arteriosclerosis. This creates an obstruction that makes it difficult for blood to leave the glomerulus, and increases pressure within the glomerulus, which leads to hyperfiltration, essentially pushing more fluid through. In response to this high-pressure state, the supportive mesangial cells secrete more and more structural matrix, which expands the size of the glomerulus. Over many years, this process of glomerulosclerosis once again diminishes the nephron's ability to filter the blood and can lead to chronic kidney disease. Although diabetes and hypertension are responsible for the vast majority of chronic kidney disease cases, there are other causes as well, including systemic diseases like lupus and rheumatoid arthritis, which can also cause glomerulosclerosis. Other causes, though, include infections like HIV, as well as long-term use of medications like NSAIDs, and toxins like the ones in tobacco. Now, normally, urea in the blood gets excreted in the urine, but when there's a decreased glomerular filtration rate, less urea gets filtered out, and therefore it has nowhere else to go besides the blood, and so it builds up in the blood, which is a condition called azotemia. Azotemia can cause general symptoms like nausea and loss of appetite, but as urea levels really build up, they can affect the functioning of the central nervous system, causing encephalopathy. This results in asterixis, a tremor of the hand that kind of resembles a bird flapping its wings, and is best seen when a person attempts to extend their wrists. Further accumulation can even progress to coma and death. This buildup can also cause pericarditis, which is inflammation of the lining of the heart. In addition, there can also be increased tendency for bleeding, since excess urea in the blood makes platelets less likely to stick to each other, and so there's less clot formation. Finally, in some cases, someone can develop uremic frost, where urea crystals can deposit in the skin and they look like powdery snowflakes. In addition to getting rid of waste, the kidneys play an important role in electrolyte balance. Potassium levels are particularly important, and normally the kidney helps with potassium excretion. In chronic kidney disease, though, just like with urea, less potassium is excreted, and so more builds up in the blood, and this leads to hyperkalemia, which can be problematic because it can cause cardiac arrhythmias. Another key role of the kidneys relates to balancing calcium levels. Normally, the kidney helps to activate vitamin D, which then helps to increase absorption of calcium from the diet. With chronic kidney disease, though, there's less activated vitamin D, so less calcium is absorbed into the blood, which results in hypocalcemia, low calcium levels. As calcium levels in the blood fall, parathyroid hormone is released, which causes the bones to lose calcium. Over time, this resorption of calcium from the bones leaves them weak and brittle, a condition known as renal osteodystrophy. The kidneys also release key hormones. For example, normally when the kidneys start sensing a lower than normal amount of fluid getting filtered, they respond by releasing the hormone renin to increase the blood pressure. In chronic kidney disease, the falling glomerular filtration rate leads to more and more renin secretion, which leads to hypertension. Now, remember that hypertension is a cause of chronic kidney disease itself, so this creates quite the vicious cycle. Finally, the kidney also secretes the hormone erythropoietin, which stimulates the production of red blood cells from the bone marrow. In chronic kidney disease, erythropoietin levels fall, and this leads to lowered production of red blood cells, and ultimately anemia. The diagnosis of chronic kidney disease comes down to looking at changes in the glomerular filtration rate over time. Chronic kidney disease might be suspected with a GFR of less than 90 milliliters per minute per 1.73 meters squared. Irreversible kidney damage might happen with a GFR below 60 milliliters per minute per 1.73 meters squared. To confirm the diagnosis, a kidney biopsy can be done to look for changes like glomerulosclerosis. Treatment for chronic kidney disease often involves managing the underlying cause. In severe situations, dialysis or a kidney transplant might be needed. Alright, as a quick recap. Chronic kidney disease is when the glomerular filtration rate falls below 90 milliliters per minute per 1.73 meters squared, over at least 3 months. Chronic kidney disease is mainly caused by diabetes and hypertension, and complications include electrolyte abnormalities, toxin buildup, hypertension, and weak bones. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other
Due to the nature of the NTB pathogenic responses and its limited exposure to the immune system, antibody responses are generally weak. If there is sufficient antigen exposure in an individual who is infected with TB, a cell-mediated immune response can be observed within a few weeks. At the onset of infection or in latent disease, there is insufficient antigen and antibody response for detection of infection by antigen or antibody detection methodologies, and under such circumstances, low-grade or latent TB infection can only be detected via the cell-mediated immune response. Antigen and antibody-based detection systems are only able to identify active TB disease, whereas interferon gamma release assays such as T-spot TB can identify both latent TB infections as well as active disease. Note that both during latent and active phases of TB infection that interferon gamma detection assays, such as T-spot TB, would be positive.
Tuberculosis is a global health problem. It is one of the most important preventable causes of death and morbidity in the world today. In the United States, the disease continues to be a significant challenge due to immunosuppressive conditions, immigration, and non-compliance with testing and treatment protocols. Mycobacterium tuberculosis, MTB, is a slow-growing intracellular organism, which makes culturing the organism slow and unreliable. Latent tuberculosis infection, LTBI, occurs when people carry Mycobacteria bacilli in their body, but the organisms are dormant and still in small numbers. These mycobacteria are controlled by the body's immune system and are still in small numbers. In this state, the MTB do not cause disease or any LTBI are not infectious. They would be negative to most TB tests, including culture and smear microscopy. Small nodules are occasionally seen on chest X-ray. Until recently, the only test capable of identifying LTBI has been the tuberculin skin test, TST. The most commonly used TST is the MAN2 test. This involves an intradermal injection of purified protein derivative, PPD, into the arm. PPD is a mixture of proteins derived from dead M. tuberculosis cultures. An immune reaction occurs within 48 to 72 hours, at which time the induration is measured. This test requires 2 patient visits. In addition, the test requires up to 72 hours to get the result, and false positives can occur in BCG-vaccinated subjects or following infection with environmental mycobacteria. The DNA of Mycobacterium tuberculosis has a region of difference called RD1 that is not found in BCG and most environmental Mycobacterium. The RD1 area of MTB encodes for 9 proteins, including ESAT6 and CFP10. These 2 proteins are used in the T-spot TB test to challenge T cells. If the T cells recognize these proteins, they secrete interferon gamma. The T-spot TB test is a simplified version of the enzyme-linked immunospot ELISpot assay technique. It identifies M. tuberculosis sensitized effector T cells activated by the presence of CFP10 and ESAT6 antigens from the RD1 region of MTB. Effector T cells are quite short-lived. Their continuing presence indicates the cellular immune response is currently encountering and fighting a pathogen somewhere in the body. Measuring the presence of effector T cells in a sample therefore diagnoses an ongoing infection. In contrast, the presence of memory T cells would only indicate that someone had been infected with a pathogen at some point in the past. Blood from the patient is centrifuged, and the number of peripheral blood mononuclear cells, PBMCs, are counted. The sample is diluted so that a standard number of PBMCs are added to each well. PBMCs are added to a pre-coated well that contains antibody to interferon gamma. Cells are incubated for 16 to 20 hours. In the presence of activated effector T cells, the TB-specific antigens, ESAT6 and CFP10, stimulate the release of interferon gamma, which binds to antibodies to interferon gamma on the base of the well. Wells are washed, and a secondary antibody to interferon gamma is added. Following another incubation and washing step, the substrate is added. This produces spots on the well floor where the interferon gamma was secreted by T cells. These spots are enumerated to provide the test result. The T-spot methodology provides an effective means of identifying TB infection. The test is highly sensitive and reliable in targeted testing groups. T-spot TB provides comprehensive testing coverage for all high-risk groups, including healthcare workers, immunosuppressed individuals, TB contacts, and TB suspects. The assay detects interferon gamma produced by T cells in response to RD1-specific peptides, so the test is also very specific. T-spot TB test results are not associated with immunocompromised status. This is because the T-spot TB test requires a standard number of PBMCs to be used for every patient, thereby minimizing the effects of low cell counts. The T-spot TB test is highly specific, as it does not cross-react with the BCG vaccine and most common non-tuberculosis mycobacteria. Benefits of the T-spot TB test are its efficiency, requires 1 single blood sample, it is fast, next day results, and it is one and done. No second visit required to read test results. Stop TB. Start with T-spot TB. Tuberculosis is a global health problem. It is one of the most important preventable causes of death and morbidity in the world today. In the United States, the disease continues to be a significant challenge due to immunosuppressive conditions, immigration, and non-compliance with testing and treatment protocols. Mycobacterium tuberculosis, MTB, is a slow-growing intracellular organism, which makes culturing the organism slow and unreliable. Latent tuberculosis infection, LTBI, occurs when people carry Mycobacteria bacilli in their body, but the organisms are dormant and still in small numbers. These mycobacteria are controlled by the body's immune system and are still in small numbers. In this state, the MTB do not cause disease or any TB symptoms. Individuals with LTBI are not infectious. They would be negative to most TB tests, including culture and smear microscopy. Small nodules are occasionally seen on chest X-ray. Until recently, the only test capable of identifying LTBI has been the tuberculin skin test, TST. The most commonly used TST is the MAN2 test. This involves an intradermal injection of purified protein derivative, PPD, into the arm. PPD is a mixture of proteins derived from dead M. tuberculosis cultures. An immune reaction occurs within 48 to 72 hours, at which time the induration is measured. This test requires 2 patient visits. In addition, the test requires up to 72 hours to get the result, and false positives can occur in BCG-vaccinated subjects or following infection with environmental mycobacteria. The DNA of Mycobacterium tuberculosis has a region of difference called RD1 that is not found in BCG and most environmental Mycobacterium. The RD1 area of MTB encodes for 9 proteins, including ESAT6 and CFB10. These 2 proteins are used in the T-spot TB test to challenge T cells. If the T cells recognize these proteins, they secrete interferon gamma. The T-spot TB test is a simplified version of the enzyme-linked immunospot ELISpot assay technique. It identifies M. tuberculosis sensitized effector T cells activated by the presence of CFB10 and ESAT6 antigens from the RD1 region of MTB. Effector T cells are quite short-lived. Their continuing presence indicates the cellular immune response is currently encountering and fighting a pathogen somewhere in the body. Measuring the presence of effector T cells in a sample therefore diagnoses an ongoing infection. In contrast, the presence of memory T cells would only indicate that someone had been infected with a pathogen at some point in the past. Blood from the patient is centrifuged, and the number of peripheral blood mononuclear cells, PBMCs, are counted. The sample is diluted so that a standard number of PBMCs are added to each well. PBMCs are added to a pre-coated well that contains antibody to interferon gamma. Cells are incubated for 16 to 20 hours. In the presence of activated effector T cells, the TB-specific antigens, ESAT6 and CFP10, stimulate the release of interferon gamma, which binds to antibodies to interferon gamma on the base of the well. Wells are washed, and a secondary antibody to interferon gamma is added. Following another incubation and washing step, the substrate is added. This produces spots on the well floor where the interferon gamma was secreted by T cells. These spots are enumerated to provide the test result. The T-spot methodology provides an effective means of identifying TB infection. The test is highly sensitive and reliable in targeted testing groups. T-spot TB provides comprehensive testing coverage for all high-risk groups, including healthcare workers, immunosuppressed individuals, TB contacts, and TB suspects. The assay detects interferon gamma produced by T cells in response to RD1 specific peptides, so the test is also very specific. T-spot TB test results are not associated with immunocompromised status. This is because the T-spot TB test requires a standard number of PBMCs to be used for every patient, thereby minimizing the effects of low cell counts. The T-spot TB test is highly specific, as it does not cross-react with the BCG vaccine and most common non-tuberculosis mycobacteria. Benefits of the T-spot TB test are its efficiency, requires 1 single blood sample, it is fast, next day results, and it is one and done. No second visit required to read test results.
It's estimated that about 2 billion people worldwide are infected with Mycobacterium tuberculosis, often just shortened to tuberculosis or simply TB. 2 billion is a lot of people, right? But even though they're infected, that doesn't mean that all these people have symptoms. The vast majority, about 90 to 95%, aren't even aware that they're infected. And this is because usually the immune system can contain it such that it isn't able to multiply, and often it remains latent or dormant, as opposed to active, which usually causes symptoms and means it can be spread to others. If the host immune system becomes debilitated at some point down the road, like with AIDS or some other illness, or as a person grows older, it can be allowed to reactivate, or basically wake up and become very serious, especially if it spreads throughout the body. Mycobacteria are an interesting bunch. They're slender, rod-shaped, and need oxygen to survive. In other words, they're strict aerobes. They've got an unusually waxy cell wall, which is mainly a result of the production of mycolic acid. Because of this waxy cell wall, they're acid-fast, meaning that it can hold onto a dye in spite of being exposed to alcohol, leaving it a bright red color when a Ziehl-Neelsen stain is used. The wall also makes them incredibly hardy, and allows them to resist weak disinfectants and result of the production of mycolic acid. Because of this wax, they're strict aerobes. They've got an unusually waxy cell wall, which is mainly a result of the production of mycolic acid. Because of this waxy cell wall, they're acid-fast, meaning that it can hold onto a dye in spite of being exposed to alcohol, leaving it a bright red color when a Ziehl-Neelsen stain is used. The wall also makes them incredibly hardy, and allows them to resist weak disinfectants and survive on dry surfaces for months at a time. Now, Mycobacterium tuberculosis is usually transmitted via inhalation, which is how they gain entry into the lungs. Now, we breathe in all sorts of virus and bacteria all the time, but we've got defenses to take care of most of them. For one, air that we breathe in is turbulent in the upper airways, and drives most bacteria against mucus, which is then cleared pretty quickly. Ultimately, though, TB can avoid the mucus traps and make its way to the deep airways and alveoli, where we have macrophages which eat up foreign cells, digest, and destroy them. With TB, they recognize foreign proteins on their cell surface and phagocytize them, or essentially package them into a space called a phagosome. With most cases, the macrophage then fuses the phagosome with a lysosome, which has hydrolytic enzymes that can pretty much break down any biochemical molecule. TB is tricky though, and once inside the macrophage, they produce a protein that inhibits this fusion, which allows the mycobacterium to survive. It doesn't just survive though, it proliferates and creates a localized infection. At this point, the person has developed primary tuberculosis, which means that they have signs of infection soon after being exposed to TB. Even though it sounds bad, most people at this stage are actually asymptomatic, or maybe have a mild flu-like illness. About 3 weeks after initial infection, cell-mediated immunity kicks in, and immune cells surround the site of TB infection, creating a granuloma, essentially an attempt to wall off the bacteria and prevent it from spreading. The tissue inside the middle dies as a result, a process referred to as caseous necrosis, which means cheese-like necrosis, since the dead tissue is soft, white, and looks a bit like cheese. This area is known as a Gone focus. TB also gets to nearby hilar lymph nodes, either carried over by immune cells through the lymph or by direct extension of the Gone focus infection, and causes caseation there as well. And together, this caseating tissue and associated lymph node make up the characteristic Gone complex. Gone complexes are usually subpleural and occur in the lower lobes of the lungs. The tissue that's encapsulated by the granuloma undergoes fibrosis and often calcification, producing scar tissue that can be seen on X-ray. This calcified Gone complex is called a rank complex. In some cases, although a scar is left over, the mycobacteria is killed off by the immune system, and that's the end of that. In other cases, even though they're walled off, they remain viable and are therefore still alive, but they're just dormant. If and when a person's immune system becomes compromised, like with AIDS or with aging, the Gone focus can become reactivated, and the infection can spread to either one or both upper lobes of the lungs. It's thought that this is because oxygenation is greatest in these areas, and TB being an aerobe prefers areas of greater oxygenation, right? Since they were previously exposed, the immune system's memory T cells quickly release cytokines to try and control the new outbreak, which forms more areas of caseous necrosis. This time, though, it tends to cavitate, or form cavities, which can allow the bacteria to disseminate, or spread through the airways and lymphatic channels to other parts of the lungs, which can cause bronchopneumonia. But it can also spread via the vascular system, and infect almost every other tissue in the body, called systemic miliary TB. When TB spreads to other tissues, it causes complications related to the organs affected. Kidneys are commonly affected, resulting in sterile pyuria, or high levels of white blood cells in the urine. It might also spread to the meninges of the brain, causing meningitis, the lumbar vertebrae causing pot disease, the adrenal glands causing Addison's disease, the liver causing hepatitis, and the cervical lymph nodes causing lymphadenitis in the neck, also known as scrofula. Testing for TB often starts with a purified protein derivative, or PPD, intradermal skin test, sometimes known as a tuberculin skin test, MON2 test, or simply TB test. With this test, tuberculin is injected between layers of the dermis. Tuberculin is a component of the bacteria, and if a person has previously been exposed to TB, the immune system reacts to the tuberculin and produces a small, localized reaction within 48 to 72 hours. If the reaction creates a large enough area of induration, rather than just redness, it's considered to be a positive test. Positive tuberculin test simply means that the patient's been exposed at some point to TB. It doesn't differentiate between active and latent disease. As an alternative to tuberculin skin tests, there are also interferon gamma release assays, or IGRAs, which look for evidence in the blood of previous exposure to TB proteins. Since this one's a blood test, you don't need to show up again to have the test read like you do with the PPD. Also, the IGRA is more specific to TB rather than other types of mycobacterial infections, and is unlikely to be positive as a result of having BCG vaccine in the past, a vaccine that protects against TB. And this is a pretty useful feature of IGRAs, since BCG vaccine is given to a lot of children around the world to prevent disseminated TB. After doing screening tests with PPD or IGRA, anyone with a positive result typically gets a chest X-ray to look for signs of active TB disease. In patients with symptoms like fever, night sweats, weight loss, and coughing up blood or hemoptysis, it's important to collect samples from either the sputum or from a bronchoalveolar lavage, which is where a bronchoscope is inserted through the mouth or the nose into the lungs. Fluid is squirted, and then that fluid is collected. These samples can then get sent to the lab for staining, culture, and PCR to look for evidence of mycobacterium tuberculosis. Treatment for latent TB infection typically involves using a single drug for a prolonged period of time. The most common approach is isoniazid for 9 months. Treatment of active TB disease is typically a combination of antibiotics, which results in patients being non-infectious to others, usually within a few weeks. Until that point, though, patients can spread TB to others, and it's typically adults with reactivated TB that are the most infectious. As a result, patients are typically kept in negative pressure rooms, and visitors are asked to wear protective N95 masks that can't filter out oil aerosols, N for not resistant to oil, but can filter out at least 95% of other aerosols, in this case, TB. Even after patients are no longer contagious, they're typically kept on multiple medications for many months to be sure that the bacteria are destroyed, usually with direct observation therapy or DOT, where somebody watches and confirms that you're taking the medications. Additionally, there's an enormous worry about new drug-resistant strains of TB that are causing infections in various parts of the world. You may hear about MDR-TB or multi-drug-resistant TB, or even XDR-TB, which is extremely drug-resistant TB, which are incredibly hard to treat because they don't die in the presence of our usual antibiotics. The bottom line is that to get an effective treatment, it's super important to make sure that the drugs being used will work against the specific strain of TB, that multiple medications are used together to prevent drug resistance from developing, and that medications are used for the entire course of therapy so that all of the mycobacterium tuberculosis is killed off. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media.
Science has acknowledged a mind-body connect as early as 1872. The Orient has had the knowledge of this important innate for thousands of years and has succeeded in developing some powerful techniques to help modulate the mind through the body and vice versa. The human body is a miracle in action. The human nervous system is made of more than 100 billion nerve cells. The nervous system relays information from the brain to the body and back. One of the most important commands central for bidirectional communication between the brain and body is the vagus nerve. A nerve probably 99% of the population never heard of nor have a clue of its location. So what is the vagus nerve? Vega in Latin means to wander. This nerve wanders around the body, impacting major organs. This being the longest cranial nerve, it controls all involuntary body processes such as breathing, speech, swallowing, heartbeat, blood pressure, hearing, taste, circulation, digestion, and gut health. It also controls bladder movement, orgasms, and fertility. A healthy vagus brain responsible for creativity, higher cognition, and complex decision making. In the absence of a healthy vagus nerve, we only end up having access to parts of our brain that control primal instincts like fear and fight or flight response. Hence, a healthy vagus nerve is essential for leadership and decision making. The functioning of the vagus
Hello everyone, this is Juan from CanHub and welcome to this tutorial where I'm going to be talking about the vagus nerve. The very first thing we see here on the screen is an image of the brain as seen from an inferior view where we can see the cranial nerves emerging. This little pair of nerves highlighted in green here are what we're interested in today, as these are the two vagus nerves emerging from the brain. The vagus nerves are the 10th pair of cranial nerves and it's the longest of the 12 pairs of cranial nerves. The name comes from the Latin and means the wandering nerve, which describes its wide distribution throughout the body, as we can see now on this image. It performs many important roles within the parasympathetic nervous system. This system is one of the two antagonistic systems making up the autonomic nervous system and is craniosacral, which means that it arises from the central nervous system in the cranium and from the sacral region. The vagus nerve actually carries 75% of the cranial parasympathetic function, so it's pretty vital for life. In this tutorial, we'll be describing the vagus nerve and its general course as a whole, and then we'll take a closer look at the right and left vagus nerves, and finally at its three functional pathways, which include the parasympathetic efferent pathway, the motor efferent pathway, and the afferent pathways. Before we continue, it's important to remember what we mean by the terms efferent and afferent. An efferent nerve is one that carries impulses from the central nervous system to the periphery, while an afferent nerve brings signals from the periphery to the CNS, or the central nervous system. I also want to draw your attention to the picture here. We're viewing the body in through its left side, showing the vagus nerve, highlighted in green, the structures it innervates along with their major arteries, and a few other structures to help orientate us. This is the view we'll be exploring in this tutorial. So let's start, and first we'll look at the general course of the vagus nerve. At the top of the picture here, we have the cranial nerves leaving the medulla oblongata. The vagus nerve on each side passes anteriorly, then dives inferiorly to leave the skull through the jugular foramen. Through the foramen, it is accompanied by the glossopharyngeal nerve, which is the 9th cranial nerve, as well as the accessory nerve, which is the 11th cranial nerve. There are two sensory ganglia in each vagus nerve at the jugular foramen, which are the superior vagal ganglion and the inferior vagal ganglion. When the three nerves pass through the jugular foramen, they go their separate ways, and the vagus nerve continues down the neck within the carotid. This video is not over yet. Continue watching now the full video at canhub.com. We have lots more videos like this one available to our premium members on our website, not to mention all the fun
All right, in this video, we're going to talk about the vagus nerve, or cranial nerve 10. This is a very, very important nerve. Out of most of the cranial nerves that we've talked about, this is probably of the most important nerves. And the reason why is it supplies so many different structures. Now, we're going to talk about a decent amount of them, but we're going to talk a little bit more in detail about the thoracic and the abdominal viscera, that parasympathetic supply, and GVA supply, more when we talk about the sympathetic and the parasympathetic nervous system in the autonomic videos. Okay, but for right now, let's go ahead and dive right into the actual vagus nerve. So as always, we're going to talk about where the nerve originates, we're going to talk about the course of the nerve, we're going to talk about the structures that it supplies, the functions of those structures, and then some just very basic clinical correlations. In this video, we won't discuss too many, and the reason why I'm going to tell you is that we're going to talk about it in more detail, and we talk about the parasympathetic nervous system in the autonomic videos. All right, so let's go ahead and dive right in here. So first things first, let's go through each fiber. So the vagus nerve has, again, so many fibers. It has GVE fibers, it has GVA fibers, it has GSA fibers, it has SVA fibers, and it has SVE fibers. Okay, so when we talk about the GVE fibers, these are the secretomotor fibers. So these are part of the parasympathetic nervous system. This is the ones that I said we'll talk about briefly, but we'll talk about more within the parasympathetic nervous system. So again, these GVE fibers are part of the parasympathetic nervous system. The GVA fibers are going to be very important too, which we'll talk about in the parasympathetic nervous system, as well as other different chapters. Okay, the GSA fibers are going to be your touch, pain, temperature fibers. The SVA fibers we'll talk about for the taste within the epiglottis and a little bit of taste buds within the pharynx. And the SVE fibers, the good old SVE fibers. If you remember, the SVE fibers are special visceral efferents, and they're supplying those muscles that were derived from the pharyngeal arches. The vagus nerve is supplying those muscles that were derived from the 4th and 6th pharyngeal arches. Okay. So let's go ahead and start off first. Let's do the easy one. Let's start off with the GSA fibers. So the GSA fibers are pretty simple, and these are going to be, again, your touch, pain, temperature fibers. So that's the first one we're going to focus on. So GSA fibers are going to be your touch, pain, temperature fibers. So what are they supplying? Okay, these guys are pretty cool because they're going to supply a lot of structures that we talked about already. They're going to supply the tympanic cavity. Okay, so they're going to supply a little bit of the tympanic cavity. They're even going to supply a little bit of the tympanic membrane. They're even going to supply the external acoustic meatus. And they'll go behind the ear and supply a patch of skin behind the ear. Okay, so what are these guys supplying so far? These GSA fibers. What are these fibers here? GSA fibers. General somatic afferent fiber, touch, pain, temperature fibers are supplying the tympanic cavity, the tympanic membrane, the external acoustic meatus, and a little bit of skin behind the ear, patch of skin behind the ear, or maybe called the auricle or the pinna. Okay, so it's supplying these structures. So these are GSA fibers, and they're going to be general somatic afferent fibers. What's really interesting about these guys is they have a ganglia. They have a ganglia, but this ganglia is actually located a little bit more superior to the other one. You know, they call this one the superior ganglion of cranial nerve 10. Okay? They also give it another name. You can also call it the jugular ganglions, okay, because it's very close to the jugular foramen. So you can also call it the jugular ganglion. All right? So what happens is these GSA fibers are actually going to come from the tympanic cavity, tympanic membrane, external acoustic meatus, behind the ear, or the auricle or the pinna, and it's going to take these fibers to the superior ganglion, cranial nerve 10, or the jugular ganglion, and then it's going to move through this hole called the jugular foramen. Now, after it moves out, it'll start moving towards the medulla. But what happens is it gives off a little recurrent branch over here that's going to go and supply the meninges. Oh, those good old meninges, right? Remember we showed that in like this kind of like orangish color here? So it's going to give a GSA fibers for pain, right, to the meninges. All right, this is an important branch here. So it gives a meningeal branch, and it gives a auricle branch. So there's two branches here. What is this one right here? This is the auricle branch. I'll put A for auricle, and then this one, I'm sorry, not A. This is not the ear. This is inside the freaking skull cavity right here. This is the meningeal branch. I'll put inframeningeal, and this one over here is going to be the auricular branch. A for auricular. Now, it comes into the medulla, and it goes to a specific area within the medulla. And that area that it goes to is actually called the spinal nucleus of the trigeminal nerve or cranial nerve 5. So what is this nucleus here called? This nucleus here is called the spinal nucleus of cranial nerve 5, or the trigeminal system, right? Sweet, got that one done. GSA fibers done. Put them in the bag, get them out of here. All right, so now let's do the next one. Let's go ahead and do the SVA fibers, because these aren't too crazy either. Let's do the SVA fibers. Okay, so SVA fibers are going to be the next one. So SVA fibers are going to be for taste. They're special visceral afferent. They're going to be for taste or gustation. But these ones are very interesting. If you remember, when we talked about this in the gustation video, remember there's going to be a little bit of taste buds here on the epiglottis, and there might be a small amount of taste buds located within the pharynx. But primarily, it's going to be the taste buds located on the epiglottis. These SVA fibers are going to be picking up SVA, so taste sensation, right? So sweet, salty, bitter, sour, umami, all those different types of taste, and it's going to go to a special ganglion. You know there's going to be a ganglion right here, a little bit more inferior. It's an inferior ganglion of the cranial nerve 9. So this is your inferior ganglion of cranial nerve, not 9, 10. Right? You have to give it another name, the nodose ganglion. No clue why, but they call it the nodose ganglion, or the inferior ganglion of cranial nerve 10. These central processes from these SVA fibers come from the epiglottis, primarily the epiglottis, a little bit from the pharynx. It's going to take these fibers up through the jugular foramen, right, from this inferior ganglion. Out of that, it's going to come out of the jugular foramen into these posterior cranial fossa, and it's going to go to a specific, it's going to go into the medulla and go to a special area located within the medulla. What is this area in the medulla that's going to supply? It's going to go to a specific nucleus called the nucleus of tractus solitarius. Sweet. And these are, what fibers are these? These are your SVA fibers. These are your taste fibers, right? Okay, done. That's it. SVA fibers done. GSA fibers done. Let's do the SVE fibers. This one's a little bit more complicated. Okay, let's do these ones in blue then. Okay, so the SVE fibers, they're going to be gaining, these are motor fibers. Remember, SVE fibers are motor fibers. They're special visceral efferent fibers. They're going to be coming from a special nucleus, right? A special nucleus right here. What is this nucleus called? We talked about the glossopharyngeal nerve. This one is called the nucleus ambiguus. Nucleus ambiguus. The nucleus ambiguus is going to give off these motor fibers, these special visceral efferent fibers. When these guys come out, right, the vagus nerve is going to continue and continue and continue, and it's going to give off some actual branches over here. You know who else is actually running with the vagus nerve? We have another nerve running with him. We're not going to talk about him all that crazy here, but it's actually cranial nerve 11. You know cranial nerve 11 is actually not drawn there. Let's do it over here so we have more room for other things. So cranial nerve 11 is also going to be running with the vagus nerve because you know it's the main motor nerve. And most of the internal branches of the accessory nerve is going to go with the what? The vagus nerve. Okay? We're just going to mention it there. Okay? Now, let's continue with the vagus nerve. But remember, it is running, this accessory nerve is running with the vagus nerve. And the reason why is it's going to give most of the motor fibers that are going to supply the pharynx. Okay. These motor fibers that are coming through here, it's also going to have another nerve with it. We'll just do this one in green really quick. Again, it's going to also be coming here. It's going to be the cranial nerve 9, or the glossopharyngeal nerve. It's going to move with this guy. The reason I'm mentioning all these is these bad boys form a plexus. They also might even have a little bit of other fibers with them too. But all of this structure here is called the pharyngeal plexus. So what is this whole structure called? It's called the pharyngeal plexus. Okay. Now let's just follow the vagus nerve for right now, just the vagus. The vagus is actually going to give supply to parts of the pharynx. There's these little sphincter muscles, basically. They're kind of like sphincters, and they're wrapping around the pharynx, the superior part of the pharynx, the middle part of the pharynx, and the inferior part of the pharynx. What are these muscles called? They're called the pharyngeal constrictors. So what is it supplying here? It's supplying the superior, the middle, and the inferior, what? Pharyngeal constrictors. So I'm going to put PC, pharyngeal constrictor, pharyngeal constrictor, pharyngeal constrictor. So they help with basically the deglutition process, being able to contract the pharynx and squeeze the food downwards or inferiorly to go into the esophagus. Let's say that we cut it off around this part here, and we'll say that from this part downwards, this is esophagus. So from this part downwards is going to be esophagus. Okay? This part here upwards is pharynx. Okay, so we know one branch so far. From the pharyngeal plexus is going to supply that, but guess what? It even has more supplies. It actually continues anteriorly, and goes and supplies most of the muscles of the soft palate. What are some of these muscles? Oh my goodness, there's so many of them. There is the palatoglossus, which basically, the palatoglossus is a muscle that kind of pulls the back of the tongue upwards. There's another muscle. All these are important for the deglutition process, which is basically the swallowing process, right? So there's two phases of deglutition, the buccal phase and the pharyngoesophageal phase. It's important within both of those processes, right? So now, because it's involved in that deglutition process, that's important to pull the back of the tongue backwards. Also, there's another one that pulls the actual pharynx upwards. It's called the palatopharyngeus. There's another muscle that also does that called the salpingo. I don't know where the heck they come up with these names, but they call it salpingo pharyngeus. It also elevates the pharynx, and it's close to the auditory tube. So we actually can pull in the auditory tube to kind of equalize the pressure between the tympanic cavity and the atmosphere, okay? So that's the salpingo pharyngeus. And then it supplies, we said, the superior, middle, inferior pharyngeal constrictors. Ooh, and the levator villi palatini, so that actually elevates the palate. And there's also the muscles of the uvula. We're not going to go over anymore, okay? So that's actually pretty much most of them anyway. So it supplies the palatoglossus, the palatopharyngeus, the salpingo pharyngeus, the levator villi palatini, and even the muscles of the uvula. All right, sweet deal. We covered that part of the SVE fibers. Sweet, sweet, sweet. Okay, now there's another part here. Okay, so let's continue on here. This other fibers here are going to come down. So that's the pharyngeal plexus. There's another one over here that's going to come over here. This is another branch, and it's still a part of the SVE fibers. This branch here, so that was the pharyngeal plexus. This branch here is a little bit more complicated, not too much more, but a little bit interesting of a nerve. This one is actually called the, specifically the superior laryngeal nerve. What does the superior laryngeal nerve do? The superior laryngeal nerve will continue, and it'll get close to the larynx. So it's going to come here to the larynx. Let's follow this guy upwards. And what's going to happen is it actually gives off two branches. One of the branches is called the internal branch of the superior laryngeal nerve. So we give off an internal branch and an external branch. We are more concerned with the external branch. So we'll show this here, but these really, I'm doing it here for the sake of showing the bifurcation point, but these internal branches, not SVE fibers. It's actually going to be a little bit of the GVA fibers. We'll talk about that a little later, okay? But now, this external branch is actually going to supply some muscles in this area. What muscles is it going to supply? You know there's some muscles in here, two main muscles that it's going to supply. Okay, let's say here's one muscle, and let's say here's another one. Okay, this is not anatomically perfect, it's just for the sake of knowing what it supplies. Okay, it's going to supply the two muscles. Let's say one of the muscles, there's two muscles here. One is going to be called the cricothyroid muscle. So one's the cricothyroid, and the other one's called the cricopharyngeus. These muscles are helping to be involved within the phonation or speech production. So they're involved within the speech production or phonation. There's another thing that we have to talk about. There's another branch here. Other SVE fibers here. Let's kind of bring it like this now. This next branch here is called the recurrent laryngeal nerve. Now there's two, what happens is the vagus, actually there's a right vagus and a left vagus. We'll talk about a little more detail when we get to the thoracic and abdominal viscera. For right now, I just want you to know that the recurrent laryngeal nerve is going to be another branch, but there is a right and there is a left. And the reason why I'm saying that is that the right actually comes up underneath the subclavian artery, whereas the left recurrent laryngeal nerve actually comes up underneath the aortic arch. So a little bit different in the course. But for right now, we're not too worried about that. I just want you to know that this nerve right now that I'm moving with is called the recurrent laryngeal nerve. Okay, so the recurrent laryngeal nerve is also pretty interesting. What the recurrent laryngeal nerve does is it actually gives off a branch here. It gives off these inferior branches. Okay, so what are these inferior branches going to do? These branches here from the recurrent laryngeal nerve, it's going to give off these branches here called the inferior laryngeal nerve. The inferior laryngeal nerve is going to go and supply a ton of different intrinsic muscles of the larynx. So it's going to supply a ton of different intrinsic muscles of the larynx. So what is it going to supply here? What is this nerve here called? What is this one here called? It's called the inferior laryngeal nerve. It's going to supply the intrinsic, what? Muscles of the larynx. Like what? Oh my goodness, there's so many of these too. There's these things called the cricoarytenoid muscles. So you actually have a posterior and a lateral cricoarytenoid muscles. You even have what's called a transverse and oblique arytenoid muscles. And then you even have what's called a thyroarytenoid muscles. Why am I mentioning all of these? Because all of these muscles are involved within speech production. So which muscles are involved in basically the speech production? The cricopharyngeus, the cricothyroid, the posterior and lateral cricoarytenoid muscles, the transverse and oblique arytenoid muscles, and even the thyroarytenoid muscles. What are they all involved in? They're all involved within phonation or speech production. How exactly? They're basically all functioning because you know you have these things called vocal cords, true vocal cords. What these muscles do is they pull on those vocal cords, and they make the vocal cords really, really tight by increasing their length, and they make them tense. So if the length of the vocal cords is increased, and if the tension on the vocal cords is increased, whenever air moves up against them, it helps to be able to produce those buzzing sounds that resonate within the larynx and the pharynx, and even within the oral cavity to produce sound, phonation, the production of speech. Okay, sweet. So that's that part. And again, what was this nerve right here? It's called the recurrent laryngeal. I actually spelled that wrong. There should be two R's, not two C's. Recurrent laryngeal nerve. And again, just remember there is a right and there is a left. The only reason I'm saying that is because the right goes underneath the subclavian artery to go into that area there and it ascends posterior medially. The left actually comes underneath the aortic arch and ascends posterior medially. Okay, but right now we know the recurrent laryngeal nerve gives off inferior laryngeal branches which supplies the intrinsic muscles of the larynx, like the posterior and lateral cricoarytenoid, like the transverse and oblique arytenoid muscles, and the thyroarytenoid muscles. All right, cool deal. Now, to continue with these, I want to bring some other fibers with them. This is why I can get a little dicey in here. Okay, so we've covered pretty much the SVE fibers. Now what I want to do is I want to bring with some of these the GVA fibers and even a little bit of GVE fibers. Okay, so moving with the superior laryngeal nerve, there's actually going to be some GVA fibers. Let's make these GVA fibers green here. So moving with the superior laryngeal nerve, you're going to have these GVA fibers. They're going to move with this actual superior laryngeal nerve, and they're going to be the main internal branch. So they're going to be the main internal branch of this nerve. The internal branch is actually going to pierce through the thyrohyoid membrane. And what is it going to do? It's going to supply the mucosa of the larynx above the true vocal cords, or above the vocal cords in general, primarily the true though, and it's going to give sensations to the epiglottis, the mucosa of the epiglottis. So what is this GVA fibers doing? These GVA fibers, which means that they're going back to picking up visceral sensations from where? From the mucosa of the larynx above the vocal cords and the mucosa of the epiglottis. Okay. What other fibers are moving in this area? You know, with the recurrent laryngeal nerve, there's also going to be some GVA fibers. These GVA fibers are also going to be coming where? They're going to be moving with the inferior laryngeal nerve, and they're going to be supplying the mucosa of what? The larynx below the true vocal cords. Okay? So just to make sure that we have this straight, there's GVA fibers moving with the superior laryngeal nerve, which are going to the mucosa of the larynx above the true vocal cords and the mucosa of the epiglottis, like the valleculae. And there's GVA fibers that are moving with the recurrent laryngeal nerve that are moving into the inferior laryngeal nerve and giving branches that goes to the mucosa of the larynx inferior to the true vocal cords. Holy crap, we got that done. Okay, unfortunately, there's other structures here too. If you guys remember this structure right here, we had the carotid bodies right here, the carotid bodies. And if you guys remember from the cardiovascular system, we also had these things called what? Aortic, sinus, and the aortic bodies, right? So you had the aortic bodies and you had the carotid bodies, right? All these dudes here. There's GVA fibers from the vagus nerve that are coming from what? They're coming from the aortic arch. There's GVA fibers that are coming from the aortic arch, and there's going to be GVA fibers that are coming from the what? The carotid bodies. Now, where do these suckers go here? Where do all these GVA fibers go? I just want to make sure that these are separate. So these GVA fibers are basically like carotid sinus branch, carotid body branch, and a aortic arch branch. These GVA fibers will move upwards, and they'll come to a ganglia. You know they have a ganglia here? It's actually an inferior ganglia. So it's actually part of the inferior ganglion, right? Or what else would you call it? The nodose ganglion. And these fibers will move inwards here. Where else would they be coming from? The GVA fibers from the superior laryngeal nerve, and you'll also be having the GVA fibers from the what else? Recurrent laryngeal nerve. All these bad boys right here are going to be moving into the inferior ganglion, or the nodose ganglion, and then where? They'll go into through the jugular foramen, and then from the jugular foramen they'll go to the dorsal nucleus of vagus. Okay? Oh, and also not just the dorsal nucleus of vagus, also they're going to go to the nucleus of tractus solitarius. And again, it's a little bit of that controversy there where it says that if you go to the nucleus of tractus solitarius in small amounts, we can go to the dorsal nucleus of vagus. The main function of the dorsal nucleus of vagus is going to be for the GVE fibers, the parasympathetic nervous system fibers. Okay, so if we want, we could really say that very little of it is going to the dorsal nucleus of vagus, and most of it is going to the nucleus of tractus solitarius. Just to revise that statement. Okay. Okay. Now, we've covered most of the GVA fibers. We're going to talk about them again when we get into the thoracic and abdominal viscera, but for right now, we've covered most of them for right now. Okay. Now, we have some more branches. Oh my goodness, right? The vagus nerve, before we start getting ready to go into the thoracic and the abdominal viscera and talking about a lot of these plexus, I want to talk about something else here. There's another thing here. These parasympathetic fibers, these GVE fibers, they can actually, there's some of them that can actually move with the recurrent laryngeal nerve. So some of them can actually move with the recurrent laryngeal nerve. And what happens is, from here, these parasympathetic fibers can come and give off branches that supply a little bit of the esophagus. And it can give off branches that come over here and supply parasympathetic fibers to the trachea. Okay? So just so we're clear here, these GVE fibers, which are going outwards, they're going to be going and supplying secretomotor fibers and muscles that are going to be, it's going to be providing fibers to the esophagus for peristalsis, and it's going to be providing fibers to the trachea for like secretion, right? And maybe even constriction too, of the smooth muscle in the actual trachea. Right? So again, what is it doing here? You're going to have these GVE fibers, and these GVE fibers are going to be giving off branches to the esophagus and other branches to the trachea, which is running along with the recurrent laryngeal nerve. Okay, now we're going to get into a little bit more of the complicated stuff over here. So now we're going to go over to this side of the diagram and talk about some of the actual thoracic and abdominal viscera. So we can keep going with those GVA fibers and those GVE fibers. But for the most part, we've talked about the GSA, we talked about the SVA, and we've done the SVE. And we've done a decent amount of GVA. Now for the big ones over here, this is where we're going to get a little hairy. The main thing over here that we're going to talk about is the GVA again. So we're going to finish up with the GVA, and then we're going to finish up with the GVE. Okay? Okay, so now there's some more branches. All right, so let's go ahead and show these branches together. I'm going to actually make them one color, and the reason why is most of the GVA fibers and the GVE fibers in this area are going to be going to the same places. If there's a little bit difference, I'll add an extra color in there. Let's make this color. Let's make it this actual purple. Let's make it purple. Okay, so now, from here, let's say that we have the vagus nerve. Let's say that we have the vagus nerve right here, and we start following some of these actual GVE fibers. Let's do the GVE fibers, and then we'll add the GVA fibers in. So some of these GVE fibers are going to make purple for right now. It's going to move downwards. As it moves downwards, it's going to give off many, many different branches, okay? It's going to give off a branch like this, okay, which is going to be going to the lungs. It's going to give off a branch that's going to go to the lungs. You know what this branch is actually called? It gives off bronchial branches, that these bronchial branches eventually come together and form this large structure here that supplies a lot of the lungs and some of the surrounding tissues around the lungs. This structure right here is called the pulmonary plexus. So again, what happens is, as the vagus nerve continues down, it gives off bronchial branches, an anterior and a posterior. And those anterior and posterior bronchial branches will actually give off and come together and eventually form what's called the pulmonary plexus. All right, sweet. That's going to supply the lungs and some of the associated bronchi, right? And these are going to be GVE fibers that can come to this area for secretion or for contraction. Now, what could be coming with it? If we're just doing this to be consistent, let's make these in black here. If we have these GVA fibers, let's say that we have here these GVA fibers. These GVA fibers can actually move where? They can go and supply the lungs. And they can also give off fibers that can go to the parts of the trachea and the bronchi. What do I mean? If you remember the respiratory system, we had stretch receptors and different types of irritant receptors. If you guys remember that, these irritant receptors or stretch receptors are actually connected to the afferent fibers of the vagus nerve. What's afferent? It's the general visceral afferent fibers. When you stretch the lungs, or when there's some type of irritation within the lungs, you can activate the afferent fibers of the vagus nerve, and that'll send it up. What fibers are these black fibers? That's the GVA fibers. Okay, so the GVA fibers are these afferent fibers that are coming from like stretch receptors or maybe even irritant receptors, like within the bronchi or even the trachea. All right, cool. Now, as this vagus nerve continues downwards, so let's continue this bad boy downwards. It continues downwards, and it gives off a boatload of branches here. So we're going to kind of bring these out like this. Okay, so it gives off what's called different types of cardiac branches. Okay, so we give off what's called a superior cardiac branch, it'll give off an anterior cardiac branch, and it'll even give off a thoracic cardiac branch. And what happens is all of these branches will actually become a part of a very, very important structure that goes to supply the heart. You know, inside the heart, there's actually going to be these intramural ganglion right here, these terminal ganglion, intramural ganglion, that'll go to the heart. What is this structure here called? This is the cardiac plexus. Okay, so again, what is this structure right here? You can have what's called a superior cardiac nerve, you can have an inferior cardiac nerve, and you can have a thoracic cardiac nerve. And these guys may come together and provide this deep structure called the cardiac plexus, which might synapse on cell bodies of the postganglionic motor neurons within what's called a intramural or terminal ganglion, which is basically in or on that tardial organ, in this case, which is the heart. What's the function of that? The function of these GVE fibers is to basically slow down the heart rate. You know, the SA node and the AV node? Remember the SA node and the AV node, which are basically acting as those conductive structures to the SA node and the AV node. The whole purpose of this vagus nerve on this area is to do what to these guys? To slow down their action potentials, to produce a decrease in the heart rate. That's the function of these bad boys. All right, cool. Now, we got to keep going here. Now, from here, the vagus nerve will also give off another branch. It'll give off this next plexus here, which will come around and supply a lot of the esophagus right here. It's going to supply a ton of parts of the esophagus. What do you think this is called? The esophageal plexus. So it's called the esophageal plexus. So this right here is called the esophageal plexus. What do you think it's going to do with the esophagus? What do you think the esophageal plexus is going to do? Whenever you're eating food, it's going to help to be able to produce this peristaltic contraction, alternating waves of contraction and relaxation to push the food downwards into the stomach. Simple as that. Then, from the esophageal plexus, it gives off two branches, an anterior branch and a posterior branch. And what are these called here? Let's say that this is called the posterior gastric nerve. And let's call this one over here the anterior gastric nerve. And this is basically going to supply the stomach. So it's going to help with the peristaltic contractions of the stomach, the mixing of the stomach, the turning of the stomach, the mechanical digestion of the food within the stomach, right? So we have the esophageal plexus, which is a branch of the vagus nerve, which causes peristalsis of the esophagus. We have anterior and posterior gastric nerves, which are going to supply the stomach to help with the peristalsis of that. This sucker just keeps going. Okay, now I got to be just a tiny, tiny bit more specific. Okay, this guy here is going to go where? This vagus nerve is going to give off branches here. Now, I have to be very, very particular here. And the only reason I'm saying this is because we actually have what's called a right vagus and a left vagus, right? The left vagus and the right vagus supply different types of plexi, okay? So the right vagus is actually going to give off a branch. Let's actually say it's right here. It's going to give off a branch here that's going to go to what's called the celiac plexus. Okay, it's going to go to what's called the celiac plexus. And the celiac plexus supplies a boatload of structures. It supplies the adrenal glands. It supplies the kidneys. It supplies the intestines. So like the large intestine, the small intestines. It supplies the pancreas. It even gives branches all the way out here to the spleen. So it gives many, many branches. So what is it going to supply? The celiac plexus, which is coming from what vagus nerve? It's coming from the right vagus. So the right vagus nerve gives off what's called the celiac plexus. And the celiac plexus supplies the adrenal glands, it supplies the kidneys, it supplies the large intestine. Now how far? It supplies the ascending colon, it supplies the transverse colon, it supplies the hepatic flexure, but it stops at the splenic flexure. So it supplies most of the colon up to the splenic flexure. It supplies the pancreas, it supplies the duodenum, the jejunum, and the ileum, the small intestine. It also supplies the spleen. Then there's another one, the left vagus. The left vagus is actually going to give off another branch. Let's actually bring it in here because it's kind of ironic here where we're at. It gives off another branch, and this is actually going to be the, let's say this one right here is going to be the left vagus. So this one right here that I'm coming off to, the right vagus is this one. This is the left vagus. The left vagus is going to go to what's called the hepatic plexus. And the hepatic plexus is going to supply the liver, and it's also going to supply the gallbladder. Okay, so it's going to supply the liver and the gallbladder. But that's specifically coming from the left vagus. So what is this plexus right here called? This is called the hepatic plexus, which supplies the liver and the gallbladder. Okay, so to make sure that we understand this, coming down, it gives off bronchial branches, which form the pulmonary plexus. What is the function of the pulmonary plexus? Provide basically fibers that can cause secretion within the lungs, or might even cause bronchial constriction. It's going to give off superior, inferior, and thoracic cardiac nerves, which are going to provide the cardiac plexus, which serves the SA node and the AV node. If you want to be really specific, SA node is really innervated by right vagus, AV node is really innervated by left vagus. What's the purpose of this? To slow down the heart rate, okay? Negative chronotropic action. Then it's also going to give off another branch. I'm sorry, over here, the esophageal plexus, which supplies the esophagus to have peristaltic contractions. Then from the esophageal plexus, it gives off the posterior gastric nerve, anterior gastric nerve, which allows for peristalsis and even secretion activities of the stomach. Then what happens? It gives off from the right vagus, you give off the celiac plexus, which supplies the kidneys, it supplies the adrenal glands, it supplies the intestines, right? So contraction and secretion of the intestines, both large and small, but it only goes up to the splenic flexure. It supplies the pancreas for secretion of pancreatic juices, and it even controls the spleen. And then if you remember from the left vagus, you're going to help perform the hepatic plexus, which supplies the liver for secretion of like bile and other different types of substances, as well as the gallbladder for gallbladder contractions to make bile, right? Or to release the bile down into the duodenum. Then what do we say moves with a lot of these? These GVA fibers, like the stretch receptors of the lungs or the irritant receptors of the lungs. You can even follow these suckers down here. They don't really have a cardiac branch, but they do have this esophageal branch. So if we follow this esophageal branch here, it actually gives GVA fibers to the esophagus. It actually moves with the celiac plexus here. It also gives off another branch that moves with the hepatic plexus right here. So if we give off another branch that moves with the hepatic plexus, what's it going to do there? It's basically going to give different types of visceral sensations from the liver or visceral sensations from the gallbladder. And it's going to give also GVA fibers that move with the celiac plexus to supply the adrenal glands, to supply the kidneys. It's also going to give GVA fibers that move to supply the intestines. This is probably the most important. So when it goes to the intestines, if you have stretch of the intestines or irritation of the intestines, that will activate these fibers. If you have, the stomach, so even from here from the esophageal plexus, it'll move into these gastric nerves. So whenever there's stretch of the stomach. So if there's stretch of the stomach, it'll activate these general visceral afferent fibers of the vagus nerve and send it up to the medulla. If there's stretching of the intestines, right? Or it can even pick up sensations from the pancreas. It can pick up sensations from the spleen. So the whole point is that what? The thoracic and abdominal viscera is supplied by what? GVE fibers, which are the parasympathetic fibers. For what? Two things. One is going to be peristalsis or some type of glandular secretion, okay, of any of these structures that we talked about. Then the other fibers were the GVA fibers. And the GVA fibers were picking up sensations, certain types of visceral sensations. From where? From the lungs, from the liver, from the gallbladder, from the stomach, from the esophagus, from the intestines, the pancreas, different parts of the thoracic and the abdominal viscera. Okay? Now, with that said, what have we covered? We've covered the GVE fibers. We've covered the GVA fibers. Okay? And we've talked about the GSA fibers, the SVA fibers, and SVE fibers. We're not going to spend a lot of time about the clinical correlations in this, and the reason why is we're going to talk about it again when we talk about the parasympathetic nervous system. We're going to go into a little bit more detail. But what I want you guys
So let's talk about inhibition and how that affects enzyme kinetics. But first, let's review the idea that enzyme catalysis can be divided into two steps. First, the binding of enzyme to substrate, and second, the conversion of substrate to product. And using this idea, you can derive the Michaelis-Menten equation, which is useful for quantitatively looking at how enzymes behave kinetically. Also remember that within that equation we have the Km, or Michaelis constant, which is defined as the substrate concentration where the speed of product formation is at 1/2 of its max value. So the first thing that I'm going to talk about is something called a Lineweaver-Burke plot, and how it allows us to look at the Michaelis-Menten equation in a different way. So what I'm going to do is take the Michaelis-Menten equation, but then take the inverse of both sides of the equation, so 1 over everything. And that'll leave us with 1 over VO is equal to Km over Vmax times S, plus S over Vmax times S, since I've separated those two terms. Now if we cancel out the two S values, then we're left with the equation that I've just drawn out. And conveniently, we can use this equation to describe a linear function. We can make 1 over VO our y, or dependent variable, Km over Vmax our coefficient m, or the slope, 1 over S our x, or independent variable, and then 1 over Vmax our b, or y-intercept. We can then plot this on a graph, with our y-axis being 1 over VO, and our x-axis being 1 over S, and if we draw out the corresponding line, the slope of our line will be equal to Km over Vmax, and our y-intercept will be equal to 1 over Vmax. And we call this plot a Lineweaver-Burke plot, and it gives us another way to look into the Michaelis-Menten equation. So let's take a step away from this idea for a moment and talk about the 3 types of enzyme inhibitors. So our first type of inhibitor is called the competitive inhibitor, and it works by binding to free enzyme, or E, to form EI, or enzyme inhibitor complex. And that'll block the enzyme and make it unable to react with substrate to form product. So in this case, our inhibitor competes with substrate for space on the enzyme. Our second type of inhibitor is called an uncompetitive inhibitor, and it works by binding to the enzyme-substrate complex to form ESI, which prevents the enzyme from turning the substrate into product. Our third type of inhibitor is called a non-competitive inhibitor, which some people call a mixed inhibitor.
What do tea, energy drinks, chocolate, cola, and coffee have in common? They all contain caffeine, the most popular psychoactive drug in the world. Almost everyone knows firsthand how effective caffeine is at keeping you awake, but how does it do it? Listen in to this episode of Medicurio to explore the history, mechanism, and surprising medical uses of caffeine. Humans and caffeine have had a long history together. The drinking of tea began almost 5,000 years ago in ancient China, while the drinking of coffee began around 1,000 years ago in Arabia. In both civilizations, caffeine became an integral part of their cultures. Tea and coffee arrived in Europe around the same time in the 16th century and likely caused a revolution of knowledge and technology in Western civilization. This was because before caffeine was introduced, due to the unsanitary water conditions, Europeans often drank weak beer and wine throughout the day instead of water. The alcohol sterilized any germs, but also made people tipsy. You can probably imagine how that would have affected productivity of workers in Europe. When coffee became popular, not only did it allow people to work energetically, it also popularized coffee houses, where people had serious discussions about current events over a cup of coffee, resulting in philosophy, science, and politics all advancing in leaps and bounds. Without caffeine, Western civilization may very well be a lot less developed than it is now. It was in the 1800s when caffeine was finally isolated from coffee, leading to extensive research on the drug. Finally, in the 1960s, scientists discovered how caffeine prevents sleepiness. But to understand its mechanism, first we need to figure out what is going on inside our brain to make us fall asleep. Cells in our body, such as neurons, break down a molecule called adenosine triphosphate for energy. One of its breakdown products is adenosine. Therefore, as the brain uses up energy throughout the day, adenosine levels steadily increase inside the neurons, leading to some adenosine exiting the neurons, which can bind to adenosine receptors to cause sleepiness. This is a very for energy. One of its breakdown products. But to understand its mechanism, first we need to figure out what is going on inside our brain to make us fall asleep. Cells in our body, such as neurons, break down a molecule called adenosine triphosphate for energy. One of its breakdown products is adenosine. Therefore, as the brain uses up energy throughout the day, adenosine levels steadily increase inside the neurons, leading to some adenosine exiting the neurons, which can bind to adenosine receptors to cause sleepiness. This is a very useful mechanism. High adenosine levels in the brain indicate that the brain has been very active and needs to rest, so adenosine will make you fall asleep. Specifically, adenosine has two effects depending on what type of adenosine receptor it activates. If adenosine activates an A1 receptor, which are found on neurons that keep the brain awake, those neurons become less active. If adenosine activates an A2A receptor, which are found on neurons that initiate sleep, those neurons become more active. The combined activation of these two receptors, a weaker wake signal and a stronger sleep signal, as well as a variety of other hormones, are responsible for making you fall asleep. During sleep, the brain can replenish its energy reserves and begins to eliminate adenosine. Eventually, not enough adenosine is left in the brain to activate adenosine receptors, so you wake up feeling refreshed. The structures of caffeine and adenosine are very similar, which means that caffeine can also bind to adenosine receptors. However, since adenosine and caffeine are not exactly the same, caffeine cannot activate those receptors. All it does is compete with adenosine for the receptors, making it more difficult for adenosine to activate those receptors to cause sleepiness. This is how caffeine makes you feel more alert, essentially by decreasing the sensitivity of your neurons to adenosine. Caffeine's effect only lasts for 2 to 4 hours though, depending on how fast your body breaks down caffeine, which is mainly determined by genetics. Once your body breaks down the caffeine, adenosine can once again bind easily to its receptors to cause sleepiness. If you ingest caffeine on a daily basis, you may have started with drinking 1 cup of coffee a day, and eventually moved on to 3 or 4 a day to have the same feeling of alertness. This is known as caffeine tolerance and often happens to people who are chronic coffee drinkers. This may be due to your neurons synthesizing more adenosine receptors to compensate for the receptors blocked by caffeine. Therefore, more caffeine is needed to block those additional receptors. If a chronic caffeine user suddenly stops taking caffeine, since there are now so many adenosine receptors, the sleep-inducing effects of adenosine may intensify. Therefore, some users may experience withdrawal symptoms such as fatigue, drowsiness, difficulty concentrating, and irritability, the opposite of caffeine's effects. To avoid these unpleasant feelings, these people will continue to take caffeine. This results in a mild physical dependence on the drug, but not severe enough to be classified as a true addiction. Caffeine is nowhere near as addictive and life-ruining as other stimulants like cocaine and methamphetamines. These withdrawal symptoms can last up to a week until the number of adenosine receptors returns to normal, and you can minimize these symptoms by slowly weaning yourself off of caffeine rather than stopping abruptly. Adenosine receptors are also found outside the brain, particularly in the heart and kidneys. Just like how activating A1 receptors in wake-stimulating neurons decreases their activity, activating A1 receptors in the heart and kidneys also decreases their activity. The heart slows down, while less blood is filtered through the kidneys, leading to less urine production. Just like in the brain, activating A1 receptors is a way to give these organs a rest as well, as both heart beating and urine production consume energy. When these A1 receptors are blocked by caffeine, the opposite occurs. Heart rate increases and more urine is produced, symptoms you may experience after a few cups of coffee. For people who have ingested a large amount of caffeine, they may experience uncomfortable symptoms such as headache, dizziness, and insomnia from over-alertness, jitteriness from high heart rate, and dehydration from increased urine production. However, caffeine is generally a safe drug. It is very difficult to overdose on caffeine. Here are the caffeine levels in common caffeine-containing substances. For caffeine to be lethal to an average adult, 10 grams of it must be ingested within a few hours, which is the equivalent of around 100 cups of coffee. A few words of caution though. Children should avoid caffeine, as it is still unknown what kind of effects caffeine has on a developing brain. And if you are constantly using caffeine to avoid sleep, stop. Adequate sleep and rest are important for healthy brain function. Aside from its stimulatory effects, caffeine also has some medicinal effects, though its mechanism there is not well understood. Caffeine is commonly found mixed with NSAIDs such as acetaminophen and aspirin because somehow caffeine can enhance their pain-killing properties. This is particularly useful in treating pain from migraines. Even more interesting is that recent research has found that moderate daily caffeine intake seems to prevent various neurodegenerative diseases such as Alzheimer's because somehow caffeine can enhance their pain-killing properties. This is not well understood. Caffeine is commonly brain function. Aside from its stimulatory effects, caffeine also has some medicinal effects, though its mechanism there is not well understood. Caffeine is commonly found mixed with NSAIDs such as acetaminophen and aspirin because somehow caffeine can enhance their pain-killing properties. This is particularly useful in treating pain from migraines. Even more interesting is that recent research has found that moderate daily caffeine intake seems to prevent various neurodegenerative diseases such as Alzheimer's and Parkinson's disease. It is truly exciting that such a common drug like caffeine may be the key to preventing the devastating neurodegenerative diseases that are affecting so many people right now. So the next time you drink a cup of coffee or tea, realize that you are taking in a drug that not only played a huge role in human civilization in the past, but may be an important medical drug in the future. Thanks for watching, and see you next time on Medicurio.
Epithelial refers to the surface lining, and ovarian refers to ovary, of which women have two that sit along either side of the uterus. So epithelial ovarian cancer is a cancer that forms along the surface of an ovary. Now, each ovary has multiple follicles, and each follicle is made up of a germ cell, also known as an oocyte, which is an immature egg. Between the follicles is the stromal or connective tissue cells, and lining the ovary is a layer of epithelial cells. Ovarian tumors are generally grouped based on these three types of cells in the ovaries, and the majority of ovarian cancers are the epithelial kind. Now, if an epithelial cell starts to divide uncontrollably, it can either be a benign tumor, which means that it doesn't invade nearby tissue or spread to other parts of the body, or it can be a malignant tumor, which means that it might invade or spread to other tissues. Compared with benign tumor cells, a distinguishing feature of malignant tumor cells is that they have slightly less organized nuclei. A third class of tumors are called borderline tumors because they have features that are intermediate between the other benign and malignant tumors. Epithelial ovarian cancers can be subdivided into 4 types: serous, mucinous, endometrioid, and transitional. Serous and mucinous tumors arise from the epithelial cells that line the outside of the ovaries, whereas even though the tumors are found in the epithelium, the endometrioid and transitional cell tumors arise from other cell types. Serous tumors have fluid-filled cysts, typically a single cyst, and can be benign, malignant, or borderline. Benign serous tumors are called serous cystadenomas, and are the most common type, and often develop on both ovaries, and typically affect premenopausal women. Mucinous tumors, on the other hand, have mucus-filled cysts that often involve large multiloculated cysts, but can also be benign, malignant, or borderline. Benign mucinous tumors are called mucinous cystadenomas, and often develop on only one ovary. The malignant type of serous tumors are called serous cystadenocarcinomas, and malignant mucinous tumors are called mucinous cystadenocarcinomas. Both serous and malignant cystadenocarcinomas are cysts with an inflamed and swollen lining, and they commonly arise in postmenopausal women. An interesting feature of serous cystadenocarcinomas is that they often contain psammoma bodies, which are plaques with calcium and cellular debris. A feature of mucinous cystadenocarcinomas is that they can cause pseudomyxoma peritoni, which is when mucinous material from the tumor spills out and collects in the peritoneal cavity. Next are the endometrioid tumors, which collects in the peritoneal bodies, which are plaques with calcium and cellular debris. A feature of mucinous cystadenocarcinomas is that they can cause pseudomyxoma peritoni, which is when mucinous material from the tumor spills out and collects in the peritoneal cavity. Next are the endometrioid tumors, which come from endometrium-like cells which are ectopic, meaning they're out of place because those sorts of cells are usually found in the endometrium. Benign endometrioid tumors often have cysts filled with dark blood, so although these are called endometriomas, they're sometimes referred to as chocolate cysts. Rarely, endometrioid tumors can be malignant, and the endometrium-like cells can spread to other areas, including the fallopian tubes and the peritoneal cavity. Finally, there are transitional cell tumors, which are also called Brenner tumors, named after the German pathologist Fritz Brenner who first discovered them. These tumors are made of transitional cells, which are usually found in the lining of the bladder. These guys are pretty rare and usually solid, as opposed to cystic like the others. So during ovulation, the follicle ruptures and releases an egg, which inadvertently leads to epithelial cell damage. To fix that damage, the epithelial cells have to undergo cell division to replace and heal the tissue. Each time cells divide, there's a chance of a mutation and the possibility of tumor formation. And this means that with more ovulatory cycles, there's an increased risk of tumor formation. So, things that are associated with a decreased risk of ovarian cancer include things that reduce the number of ovulatory cycles, like pregnancy, breastfeeding, and oral contraceptive use. On the flip side, some things that are associated with an increased risk include certain medical conditions, like endometriosis and polycystic ovarian syndrome. There are also some genetic risk factors, like having the BRCA1 or BRCA2 mutation, which are both autosomal dominant mutations, which in addition to ovarian cancer carry with them an increased risk of breast cancer. There's also hereditary non-polyposis colorectal cancer, also known as Lynch syndrome, which increases the risk of developing a number of cancers, including ovarian cancer. Generally speaking, symptoms of ovarian cancers can be subtle and nonspecific. Common early symptoms can include abdominal distension, bloating, as well as abdominal or pelvic pain, which can come from an ovarian torsion, where the ovary gets twisted. Occasionally, ovarian tumors can cause ascites, abdominal masses, bowel obstruction, or dyspareunia, which is pain during sexual intercourse. A classic finding is a Sister Mary Joseph nodule, which happens when the cancer metastasizes to the umbilicus. This finding is often linked with a few types of cancer, one of which is ovarian cancer. Diagnosis of ovarian cancer typically involves looking for specific tumor markers like BHCG, as well as having a transvaginal ultrasound. Tumor biopsies are done to figure out whether a growth is benign or malignant, and imaging with a CT or MRI scan can be done to look for evidence of metastasis. Treatment of ovarian cancer typically involves chemotherapy, surgery, and sometimes radiotherapy. Surgery might be enough for malignant tumors confined to the ovary, whereas chemotherapy is a protein or chocolate cysts and transition associated with increased cumulative amount of time a woman spends in ovulation, and decreased risk is associated with pregnancy, breastfeeding, and oral contraceptive use.
Hello everybody, I'm Kelsey Mantoni, UMass Med Class of 2018, and you are watching a very special student episode of the 12 Days in March Step 1 video series. This presentation will cover the often overwhelming topic of ovarian tumors. This topic can be intimidating due to the sheer number of tumors, but each tumor really has one or two distinguishing factors that sets it apart. Being able to distinguish between these tumors can lead to quick points on test day. We will start our discussion with this amazing rendition of an ovary to help us make a broad outline of where these tumors can originate. The ovary is made up of epithelial cells, sex cord cells, germ cells, and finally, we will touch on one key metastatic tumor. Now that we have our broad outline, we can organize all the tumors we will need to know, starting with the most common epithelial tumors. These include serous cysadenocarcinoma and mucinous cysadenocarcinoma. It also includes the much less common and much less commonly tested Brenner and endometrioid tumors. We will briefly cover these two tumors, but please don't devote a lot of tests studying to them. The germ cell tumors include dysgerminomas, yolk sac tumors, choriocarcinoma, teratoma, and embryonal. Sex cord tumors include granulosa cell tumors and Sertoli Leydig cell tumors. Even though these cells are more commonly seen in the testicle and testicular cancers, they can cause ovarian tumors too. Rounding out our tumors include the metastatic Krukenberg tumor. So I know that sounds like a lot, and how the heck are we going to tell them apart? Well, we're going to do that first by who is the patient in the question sum. This is rarely a distinguishing feature, but it can give you a big clue. And number one, we're going to base it on histology. As with most tumors, this is really where the money is. Other distinguishing features can be gross appearance, tumor markers, or physiology. So what will a typical question look like? It will start with the age of the patient as usual, but this can really help you narrow down your tumor, so pay attention to it. Then it will go on to describe some signs and symptoms. Could be fullness, pelvic pain, constitutional symptoms, but these symptoms generally aren't key because they will almost always then give you that they found an adnexal mass on exam. There is one caveat to this that we'll touch on later with sex cord tumors. Then they'll give you some pathologic description and expect you to either make the diagnosis or take it one step further and ask about a tumor marker. And that's it. there is really no creative way for them to come at you with this topic. Just two quick points. One is